All right, so we're going to talk about a little bit, as we move on, we're going to talk about some treatments that are a little bit more time consuming and perhaps a little bit more involved. Postural drainage is a treatment that isn't very, not very physical on our behalf, but it is a great treatment that we can perform on some of our patients that have been unable to clear some secretions out of their lungs, or having difficulty breathing, or with gas exchange because of these secretions that are trapped. Now, we have some things to consider, however. You can see the positions behind me, and some of them you can see that they're in the Trendelenburg position, right? So certain things that we want to make sure we consider before we treat our patients, because before we perform any of these postural drainage techniques, we would have already reviewed the patient's chart, if there is one. We would have already done our subjective interview. We would have done our evaluations, ranging from just taking your general vital signs, blood pressure, respiratory, heart rate, O2. We are observing the room if they're in an inpatient environment, seeing kind of what things we're against, what IVs or what lines. And we're going to make sure that the patients aren't on any active nutrition that is not, that they're not eating themselves, such as tube feeds. Because if so, we want to make sure that we confirm that we can turn them off. There's a reason for that. If a patient has eaten recently within like 30 minutes, it is unlikely that they're going to tolerate us putting them in a Trendelenburg position. If a patient has increased intracranial pressure, if they're a neuro patient that has had a head bleed or some trauma, we also don't want to put them with their head down. If a patient has running tube feeds, we don't want to put them down because they can aspirate. So we want to make sure that we can turn those tube feeds out. Some of these positions, a lot of patients won't be able to tolerate. So we want to make sure that we can modify them. Some positions, we can actually place the patient on a chair. For example, you see the posterior apical segment. If a patient doesn't want to go back to bed or doesn't tolerate being in the bed, we can perform that position in a seat. We can instruct them to perform this position in the seating manner. Now, the way that postural drainage works is by positioning a patient in your desired position after you have already looked at their x-rays, auscultated, confirmed that they have some consolidations in their lungs, placing them in a position that is going to allow gravity to move some of those secretions from where they are currently through the anatomy of the trachea so that the patient can actually expectorate them. Usually we try to place patients in these positions for about 15 to 20 minutes, depending on how much they can tolerate, maybe less if they can tolerate these positions. This is not a treatment where you place your patient in the position and you walk out of the room and come back 15 minutes later. We stay by the patient, we assess them, we ask them continuously how they're feeling, and we look at we also are going to assess their vital signs if able to. But essentially, we are going to place your patient in an array of positions, not all of these positions, only the ones that are appropriate for the lobe or the segment of the lung which has been affected, in order to promote mobility of those consolidations up the anatomy through the respiratory tract so they can actually cough them up themselves. And if they cannot cough them up themselves, that's when we intervene as well and come in with some assisted coughing techniques that we'll cover here in just a minute, or educate them on coughing as well. With any of these postural drainage techniques, whether it's these ones or the more advanced ones that we'll do next, we want to make sure that we also tell the patients that the effects of the drainage themselves might not be immediate. It could take several hours for them to start coughing stuff up, and that's totally normal. We want to be very, very sensitive and aware of patients that are in intensive care units that have a lot of other comorbidities, patients who are maybe pregnant, abdominal incisions, or any other lines or tubes that we need to kind of fiddle around. But we need to make sure that we prioritize postural drainage should it be applicable to the treatment session.
The other thing is, if your patient can't tolerate this upright posture or leaning on their knees, you can also have them lean on a raised bed and just kind of have them lay their head on their arms so they're not having to do a lot of support. This is still going to get that posterior apical segment that we're looking at getting. So I just want you to think about that we should modify these positions as patients' tolerance enables. Sometimes they don't always tolerate the position we necessarily want them in, but sometimes even just putting them in a sideline position, for example, can help start moving those secretions. One of the best things for us to get moving secretions is movement. So if we can even just alter their position so they're starting to get some movement of secretions and starting to get some deeper ventilations and work with coughing initially, we may be able to help them better move our secretions.